For Creamer Media's Polity, I'm Shannon de Rehove. I'm speaking to Consultancy Africa Intelligence consultant Deanne Goldberg and South African Business Coalition on HIV and AIDS CEO Brad Mears about health financing and national health insurance in South Africa. Your paper states that an estimated 8.3% of South Africa's GDP is spent on healthcare. Of this, 4.1% is spent on 16.2% of the population using private sector healthcare services. The remaining 4.2% serves the 83.8% of the population using public healthcare services. How does the South African government's proposal for NHI propose to correct this situation?
That statement is one of the opening statements of the NHI Green Paper, introducing, I think, the issue around the disparity in healthcare services available to South Africans. What that statement is highlighting is the fact that a small minority of the population accesses a highly resourced service, while the remainder, that 84%, access under-resourced facilities, and there's a concern around that. So what the NHI aims to do is create a system of universal coverage which allows for equitable health access across the board.
The main question I think that many people would like to know is NHI affordable? How will it be paid for?
I think that is a considerable issue for a number of people. There is a huge anxiety around NHI. So just in terms of the overall implementation plan, the envisioned cost over the 14-year implementation plan is 255 million rand. The mechanism for payment has been identified as a risk-sharing mechanism by which the risk to households and individuals as a result of healthcare spend will be reduced. The way that the NHI envisions doing this is creating a system whereby each individual in South Africa who is above a certain income threshold is required to pay. It is a mandatory contribution. Individuals who fall below that income threshold will not be required to pay. All individuals, however, will have NHI membership in that when they present for care at a healthcare facility, they will be afforded that care. It's linked to their ability to pay in that it's linked to their income. Individuals who are able to contribute more will be required to contribute more. Individuals who can't contribute as much won't be required to do so. And the final issue is that employers will have a role in implementing that. They will, same way they will handle UIF contributions, they will do the same thing for NHI.
Now, you note in your report that the DA has noted the lack of choice in the NHI. Can you elaborate?
That is one of the critiques that has been levelled against the NHI, in that as the healthcare system currently stands, you have medical scheme options, private healthcare options versus public healthcare. And I think there is an anxiety around the quality of care provided in public facilities. But what the NHI is now trying to do is to say that the standards will be increased across the board. So to reduce that anxiety around the quality of care you would be receiving. But that issue remains around your ability to choose what you want. So in terms of stepping up, the NHI aims to make quality equal across the board through the Office of Health Standards Compliance. Apparently 94% of facilities have been audited already, according to the Health Minister's statement recently. But yes, that issue around choice remains a personal one, I think.
You asked earlier whether we thought that NHI was affordable. I think it's very difficult for us to provide an unequivocal answer because of the lack of information that is around in respect to the current policy document, the current green paper that exists. There's not enough information for us to be able to make a finite determination as to whether NHI is affordable. It's a very subjective question that you're asking because it varies from person to person, sector to sector, and instance to instance. And so you need to ask yourself the question, if we had to fast forward ourselves for the next 30 years, looking at the fact that we are burdened by the highest burden of HIV in the world. We have a number of other chronic communicable and non-communicable diseases which place a massive burden on our healthcare system. Can we ask ourselves in that context whether NHI is affordable or not, and whether we don't need to make some very significant changes to our healthcare system now in order to overcome those problems within the next 30 years. So that requires a modicum of pain to be experienced by all across the country in respect of a contribution that needs to be made. So in its current format, I think that there are a lot of worries that are held by the private sector and sectors within the private sector about the affordability of NHI. For example, the current green paper doesn't allow for that choice that Deanne referred to earlier on. There are current private closed and open medical schemes, to which people pay premiums to, and they get relatively good healthcare through those schemes. Now, the NHI says that if a person chooses to continue contributing to those schemes, they're not given a choice between NHI or that scheme. They have to contribute to both, and that includes employers. So there are a number of wind-down scenarios that employers need to consider. Do they choose NHI? Do they choose private medical schemes? And if they choose private medical schemes, they've got to pay for both in its current format as the legislation is set out. What's been indicated now by many young people is that when they're entering into the formal sector and the private sector, they are actually turning down the option of joining a medical aid because they know that NHI is coming along, and they're simply saying, why must I contribute to a private healthcare medical scheme, because I'm simply just going to go and use the NHI system. So I think that it depends on how you want to carve this beast up in determining whether NHI is affordable or not. And it is very subjective. And I think it's also determined by the quality of the healthcare that is going to be provided through the public healthcare system. So I think that it's affordable if you're getting good quality healthcare. It's not affordable if you're going to go to that very same public healthcare institution and receive low quality healthcare. And so it's a very subjective situation that you're going to find yourself in. And I think the other thing that we need to recognize is that the standard of public healthcare delivery in South Africa is not uniform across the country. So you've got better healthcare systems in the Western Cape in comparison to what you might have in the Free State or in Limpopo, for example. So you've got to ask yourself the question, is the population of South Africa going to be receiving equal access to healthcare across the country in the context of an NHI system being implemented? The last point that I wanted to make at this point in time is it's very much the devil is in the detail, and the devil is also in terms of how NHI is going to be delivered. If this is going to be a system which is going to be hallmarked by corruption, maladministration, poor record keeping, lack of systems, lack of professionalism, which has been the history within the healthcare department up until now, then I think that we'd probably adopt quite a cynical view of whether NHI is going to work or not. If, however, we can break with the past and show that a system can be professionally established and professionally run, then the scenarios might be very, very different. The last caution that we need to be very careful of is that any fund that gets established, and one as big as NHI, is always going to be vulnerable and unsustainable in the short term. And so it is absolutely key that the focus be on ensuring the sustainability of NHI in its inception. Because if it's used as a convenient mechanism to capitalize the healthcare system as opposed to provide services, that would be another sincere worry that the private sector would have about the affordability of NHI.
You state in your article that collaboration between private and public service providers is essential. Do you think that private healthcare providers are willing to assist public institutions, and what benefit will this have for private healthcare providers?
Given the across-the-board implementation of the NHI, I think there really is little alternative to collaboration. I think that the private and public healthcare providers, there has been some anxiety around their relationship. But from what I have read in terms of comment by private providers, is that there is a dedication to relationship development in order to ensure accountability and sustainability. And public comment by some of the major medical schemes has been supportive of the NHI, stating that given an effective implementation, they think that it will strengthen the South African healthcare system. But they also believe that there will be a role for both players.
In the beginning, Deanne spoke about the inequitable spread of financial spend in respect of healthcare spend in South Africa versus the private sector versus the public sector. There's also an imbalance in terms of capacity and systems. And so you are asking, positioning an either-or scenario. It's either no NHI or an NHI where you see the deconstruction of the private sector healthcare insurance industry in South Africa. And I think that the only alternative is that there is collaboration between the private sector, in terms of your service providers and your deliverers of healthcare, as well as your insurers with government. And I think that if one can elevate the conversation to a level where, for example, the capacity and the expertise and the professionalism that has been developed within the private healthcare sector can be shared with government, it then provides a lot more hope in ensuring that NHI will be a success. So, for example, some of the most groundbreaking modern healthcare systems are possessed by some of our insurers in this country. And we know that the conversation that's happening between them and government is such that there is a willingness to share those systems to ensure that a system like NHI will be a success. Without those systems in place, NHI will fail. So if there's the level of dialogue is such that there's an openness between the public sector and the private sector for a sharing of resources, sharing of systems and experiences as well, in terms of making sure that NHI doesn't fall into the pitfalls that many of the private sector bodies may have experienced themselves, then I think that we are entering into a much more positive realm than where we might have found ourselves had that not been the situation.
The Department of Health, through the NHI, proposes that all citizens of South Africa be provided with essential health care, regardless of their employment status and ability to make a monetary contribution. Will this make medical schemes null and void?
The idea that the Green Paper presents is that no, it won't make them null and void. There is actually a section in the Green Paper titled The Role of Medical Schemes. What they are suggesting is a shift in understanding of the role of medical schemes. They suggest that medical schemes will now function more, they call it as a top-up. All South Africans, regardless, as you say, of employment status, will have access to a basic benefits package. So those services that are covered under that will be accessible to everyone. Those individuals who are able to afford or require more treatment or more specific options that they wish to purchase will be able to do so. And that's the way that the Green Paper puts forward a role for medical schemes.
We need to make some acknowledgements. I think the majority of South Africans don't have access to insured healthcare anyway. So it's not as if there's going to be business taken away from the current healthcare schemes, because it's based on an affordability delineation now. I mean, most people can't afford to pay for health insurance in South Africa. I think that what we can be sure of is that the package of services and the shape that the current medical scheme sector is in at the moment will be very different, and it'll offer a very different package of services to its clients going forward.
What are some of the main critiques and potential challenges relating to NHI, and how will these be overcome?
One of the ways I've heard the NHI critiqued is strong on the what but less so on the how. And I think that that's really where people's anxieties are arising, because it's given a lot of good concepts, but there's very little information about the operationalization of that implementation plan. And there are some gaps. It's important to remember that at the stage of development of being a green paper, all the operational plans are not necessarily specified, and there is consultation given the call for public comment that was allowed for after the release of the green paper. It hasn't been consolidated in a white paper as it stands at the moment. So there are gaps around that information. In terms of the lack of a white paper around the timeline issue, it was supposed to have been released already. However, if you look at the initiation of the piloting process, if we look at that as perhaps rather formative research into concretizing the plans given specifications understood from that process, I think that might be considered more valuable in terms of overcoming it. Another critique that has been levelled is around the financial specifications, in terms of, we spoke earlier about the lack of clarity about who would be required to pay and how much they would be required to pay. And another link that has been raised around finances is that estimates are projected using current inflation rates rather than accounting for spend over the years. The other concern I think that is coming up in terms of what the NHI Green Paper specifies is that the benefits package will be provided with these basic benefits, but there is no specification of what these will include and how these will be defined.
There's also a couple of other concerns. One is that the focus of government at present is on the revitalisation of the primary healthcare system in South Africa, and very often that's not where your it's the kind of the cheaper end of where your expenditure takes place. So I think that's where a lot of the revitalisation and a lot of the focus is going to be. But in terms of many of the populations in the private sector, for example, primary healthcare might not be an area of focus. It might be, as you say, hip replacements or high-end and high-cost type of medical procedures. So I think that that's the one concern. I wanted to just go back to the concern that you raised around the DA's criticism that there's a lack of choice. And I think that is an argument, but it shouldn't be an argument for the rejection of NHI out of hand. Because I think that there needs to be a holistic national approach looked at when we look at the national interests of the country. Health and healthcare and access to quality healthcare is the next frontier through which we need to break in terms of the evolution and the development of our democracy. If we don't do that, then South Africa is never going to progress economically. Earlier, Deanne spoke about the health spend per capita in South Africa. Something like 8% of our budget goes towards health expenditure. Yet, contrary to that, we've got one of the poorest health outcomes versus that health spend. And so we need to be looking at what our health outcomes are versus the amount of money that we're spending. And that's the balance that we need to get right. So if the DA, for example, criticizes government about the lack of choice, there are a lot of other national imperatives that are, in a sense, being imposed on South Africans where there is no choice. And perhaps that's the compromise that we need to make in order to make sure that we've got decent health outcomes going forward into the future. So I really would appeal that we don't get ourselves drawn into parochial debates and over-legalistic debates about the benefits and the demerits of NHI, but rather what we look at is we look at a more holistic national debate about what's in the interest of the country, both for its people as well as for its economy.
The NHI is to be phased in over a 14-year period. Can you tell us more about the initial pilot projects that are to be undertaken in phasing in NHI?
The pilot implementation phase began on the 1st of April, so there isn't all that much information available, but there have been 11 districts identified nationally, the most being in KZN, who should be acknowledged for actually having taken on an extra district voluntarily. Basically, the rollout has been specified to each of the provinces, and there are certain, they've spoken in public comment towards non-negotiables, including things like having sufficient supplies, medical supplies, vaccine for children. They talk towards making sure that the infrastructure is sufficient to support that rollout. And the other thing to note is that support teams have been dispatched to each of the districts to support that implementation, to upskill the staff and to streamline operational processes.
One of the concerns that we have is the overemphasis of a biomedical response to many of our diseases in South Africa. And we support a biomedical response, don't get us wrong, but I think that there needs to be an even-handedness and a balance between a biomedical response versus a behavioral change that we need in our country. And so I think that we have just entered into the realm and into the sphere of getting our biomedical responses right. And that is going to be perpetuated and resourced by an NHI. What we need to now start looking at is broader behavioral change, which is where SAPCOA has focused a lot of its energies. It's shifted its focus from purely on HIV and AIDS and STIs. It's now looking at wellness, for example. So all of its 7 strategies that it has in all the provinces around the country have now broadened its focus, broadened its mandate to focus on wellness as opposed to just HIV and AIDS and STIs.
In the NHR, they actually detail a move away from a hospice-centric curative approach to becoming more inclusive of preventative strategies, to ensure that level of holistic care, to allow for communities to be treated at a preventative level, rather than just moving at that hospice-centric curative biomedical approach.